Hi guys, I guess we're going to get started. I want to thank everybody for coming tonight. We're pleased tonight to have Dr. Clayton Eisworth join us, take time out of his busy schedule. He's a pulmonary critical care specialist, and he's the second Eisworth, the second generation Eisworth. His dad, and many of you know, Dr. Clem Eisworth was here for 15 years, maybe 20 years. Yeah, so Clayton's the second generation, and you know, when we talk about AFib, we talk about all the reversible things we can go attack: caffeine intake, alcohol intake, nasal decongestants. Of all the ones we talk about, probably sleep apnea is right at the top. So Dr. Eisworth is going to give us his perspective on it, and then we have time for questions after. Thank you.
I think I'll be able to project. If you guys can't hear me, let me know. And I'm Dr. Clayton Eisworth. We're going to be talking about obstructive sleep apnea and a little bit about how it ties into atrial fibrillation. The first thing, what exactly is obstructive sleep apnea? Well, sleep apnea is just recurrent interruptions in your breathing pattern and oxygenation during sleep. And particularly the important one that relates to atrial fibrillation is obstructive sleep apnea. And essentially, right here, this is sort of the normal airway cut through. So this is your hard palate and soft palate. This is your tongue, which actually extends way back further than you would think, and nasal passages. And normally, when you're wide awake, or if you don't have obstructive sleep apnea, this area stays nice and open. But you have muscle tissue here and in some stuff on the sides here that as you sleep, that all relaxes and your tongue relaxes. So if you have sleep apnea, these areas close off. The soft palate can hit the back of the throat, the tongue can come down, these areas to the side, your tonsils, your uvula, everything can kind of collapse down as you sleep, as you lose muscle tone and relax, and that can lead to sleep apnea. This right here just shows the ranges of someone who has the most open space in the back of the throat versus least. And you can see as you get more and more soft tissue, this space gets pretty crowded out. So common symptoms to be concerned about for sleep apnea. I'm not going to go through all of this on the list, but the big things, the things that your wife or your husband will knock you about is snoring, pauses when you sleep, waking up gasping. Those are pretty common. Usually if we get a story like that, it's highly suggestive that someone's going to have sleep apnea. Some people just have things like restless sleep. And then daytime symptoms are things that are often ignored by people in terms of worrying about sleep. Other than daytime sleepiness, everyone kind of thinks of it. Early morning headache is a big sign that you're not getting good oxygenation at night and your oxygen levels are dropping. And so that's something that is a red flag for concern for sleep apnea or other problems during sleep. Irritability, falling asleep during routine activities, poor concentration can also sometimes be associated with sleep disorders, particularly sleep apnea. So, heart disease and obstructive sleep apnea, one thing is that they share a lot of the same risk factors. So, being overweight, smoking, poor diet, high salt intake, cholesterol, alcohol, family history, all these things, they're kind of shared by both sleep apnea and atrial fibrillation and other heart disease. When you look at specific heart disease and obstructive sleep apnea, high blood pressure, if you look at everyone who has high blood pressure, 37% have sleep apnea versus about 10 to 12% in the general population. If you look at people who are on multiple medications and still don't have control over their blood pressure, 83% are found to have sleep apnea. For atrial fibrillation, it's about half, it's 50-50. And if you look, specific group, if you look at males with congestive heart failure, I believe over 65, 76% of those have sleep apnea. So the overlap of this disease can be very, very high with other heart diseases. And atrial fibrillation is that 50% of people with atrial fibrillation have sleep apnea. So one of the big questions is it the chicken or the egg? It gets into sort of some complicated physiology. Obstructive sleep apnea can be caused by or contributed to by in general, poor health, poor eating habits, weight, salt intake, things like that. But it also severely affects the health of multiple organ systems. And it tends to be a catch-22. So atrial fibrillation is one of the many connections with heart disease that are connected to it. Also, there's a connection between stroke and the sleep apnea. Obviously, some mood disturbance and poor sleep. Diabetes has a strong association. Obesity, reflux, even waking up in the night needing to use the bathroom. Particularly in terms of atrial fibrillation and how the two disease processes connect. When you have obstructive sleep apnea multiple times every hour, your oxygen levels are dropping down and staying down. That in turn causes the blood vessels in the heart and the lungs to respond to that low oxygen level and puts additional strain on the heart. That also leads to something called a vagal response during these episodes, which then raises up your catecholamines, which are essentially your stress hormones. The same thing, many are on a beta blocker for atrial fibrillation. This essentially, sleep apnea is causing a surge of what that medicine is designed to block. Additionally, there's some evidence, or at least theoretical, and this gets a little complicated, that with atrial fibrillation, and particularly when it's going in and out, that changes how efficient the heart is at pumping blood and will cause sudden changes in the pressures in the blood vessels that are within the lungs. And those changes to blood pressures in the lung themselves actually causes some reflex signals back to the brain and kind of can end up reducing respiratory drive and worsening sleep apnea. And so they think it's kind of an overlap. Atrial fibrillation can cause or worsen sleep apnea, and sleep apnea can cause or worsen atrial fibrillation. So when to worry about sleep apnea? Well, usually the vast majority of the times we get involved is because a spouse is concerned about the snoring or the witness apnea, or someone gets admitted to the hospital for something, routine ablation procedure or something, they get noted while they're sleeping, their oxygen's going down. But that's not really how we like to catch all of these procedures, catch all of this diagnosis and start working it out. So diagnostic screening, this is the most common. It's been around for about 25 years, is the Epworth Sleepiness Scale. It just goes through a series of questions and asks how likely is the chance that you're going to fall asleep. And you sort of self-score, 0 for no chance, 1 for a slight chance, 2 for a moderate chance, and 3, it almost always is going to happen. So sitting and reading, watching television, sitting inactive in a public place, like a lunch without alcohol, something like that, being a passenger in a car for an hour, if you lie down to take a short break in the afternoon, sitting and talking to someone, sorry, I mentioned lunch, and then in a car while stopped in traffic or a red light if you fall asleep. One of the highest that I've ever seen on this was in a truck driver who wrote that in a car while stopped in traffic he very often fell asleep. So it can be a little scary times filling this thing out, but this gives you a summary of numbers in terms of what your likelihood of sleeping is. You add it up, and this is sort of a good screening test. So less than 10 is considered a normal amount of just average person being asleep. And the higher you get on the scale, anything higher than 20 is highly, highly, highly likely of having sleep apnea. We typically would consider diagnostic screening in someone with a sleepiness scale higher than 10, particularly if they have another risk factor. So atrial fibrillation, difficult to control blood pressure, being overweight, those kind of things. So if you do that screening, you talk to your physician, you're worried, and they decide that you need a sleep study. That's how you diagnose sleep apnea. Traditionally, this evaluation of sleep was always done in an in-lab study. They tried to make it as close to a hotel room as possible, but as most of these, other than in one hospital that was actually in a hotel that they set it up, it's still in a hospital. There's all the noises, just the piping and everything. As comfortable as they try and make them, they tend not to be. And more importantly, you take that room, which is not your nice comfortable bed and what you're used to, and then you stick on all of these different monitors. This picture is a nice idealized version of a person sleeping comfortably. This is a more realistic version, a selfie from someone in a sleep lab. So you have dozens of wires and different monitors on. These are actually checking on the forehead and sides of the head, or checking brain waves to determine levels of sleep that someone in. They have some bands across here. They're checking your effort for breathing from both your chest wall and your abdominal wall, effort for breathing. It's hard to see here, but you can kind of see them here. They have a little flow sensors on the nose here, and sometimes often on the mouth as well, to check for both flow and changes in temperature. And then they check the oxygen saturation, which is very important. And that, all of this stuff kind of gets done at once, and you're monitored. So you can imagine the biggest problem with this is falling asleep. But we do tend to get very good results here. Only about 1 out of 20 people is having so much difficulty falling asleep that we actually don't get useful information. But this is not the most convenient of settings. You typically are having to get into the sleep lab around 7 or 8 at night. You're not leaving until around 7 in the morning. It's kind of disruptive to the day. And so more recently, I have a little bit of, in my opinion, an easier option, particularly when we're worried about something like sleep apnea. And so that is a home sleep study. This is kind of the idealized version of it, someone resting comfortably. There weren't a lot of selfies of this, so I couldn't have trouble finding. But here you can see real world. This is the abdominal band. There's a chest band, and then you can't really see it because of this pillow. But there's just this small thing that comes underneath here that's measuring flow. It's almost like an oxygen nasal cannula. And right here is the monitor for oxygen levels. It just clips onto the finger. So a lot less wires. It's a lot easier. It's in your own home. It's in your own bed. So it tends to be enjoyed more for patients. They find it's a little bit easier. It's more reliable to get sleep, but the problem is there's no monitors actually monitoring brain waves, so we don't actually know when someone's sleeping. So you essentially put this on, you turn it on, and then when you're up in the morning you turn it off, and we don't know how much of that night you're actually sleeping. So it's convenient. Insurance loves it because it's cheaper. The disadvantages are for other sleep problems, particularly other than sleep apnea, it doesn't help at all. It can't rule out sleep apnea. So if there's someone who has a truck driver or someone who has very high risk, it's not a good test. They have to actually do the in-lab test. And finally, the only other limitation, the treatment options that we can glean out of this study is limited to something called auto CPAP that we'll talk about later. But oftentimes, if that's not going to work, we end up needing to get additional testing in a lab. But it is certainly much more convenient and easier to do this at home, at least as a first step for the vast majority of people. So when we get a sleep study, this is actually all of the data from an entire 30 seconds of a sleep study. And so this would go on for often 6-8 hours of information. So there's a ton of information. I'm not going to bore you guys through any of this, but this is actually brainwave monitoring. Down here, this is the chest efforts, heart rates monitored on these down here, and then this is some muscle signals that are going through. But there's a ton of information on a standard sleep study. When we do the home sleep study, the only things that we get are this guy, this pulse ox number right here. We don't get a heart rate or heart rhythm, and we don't get any of the muscle monitoring or the neurologic monitoring. So it is a lot less information, but it's still enough for us to oftentimes get a good diagnosis of sleep apnea. So what really comes down to when we're trying to diagnose sleep apnea, it's all in one number. It's called the Apnea and Hypopnea Index, or AHI. And if you get diagnosed, it's important to know your number, where it started, and how you are with treatment. So under 5, so these are events per hour, is normal. 5 to 15 is considered mild obstructive sleep apnea. In Europe, that's not actually even treated or called sleep apnea. In the U.S., we consider treatment, particularly if there are other medical issues involved. So again, if you have atrial fibrillation, high blood pressure, that's difficult to control, obesity, those would be reasons to consider treatment. 15 to 30 is moderate obstructive sleep apnea. You always want to be treated, but there are a couple different options that we can try, particularly if someone's resistant to using a positive pressure system. And then greater than 30 is severe obstructive sleep apnea, and essentially is always going to need either CPAP or BiPAP. Just talk about treatment options here again. So just to remind you guys of all the things, the uvula, the tonsils, the soft palate, and all these areas that are pushing up against the tongue can be what drives sleep apnea. So there are some oral appliances that kind of push the lower jaw forward, kind of opening the space up a little bit, creating a little bit more room. And that can work in more mild cases of sleep apnea and be fairly successful just as a dental appliance. The problem is that there's no way that this is not electronic. It's just a simple kind of piece of comfortable plastic that you put your mouth on. So there's no way to test how successful this ends up being. More often, these end up getting targeted and marketed to either people who have just very mild, without risk factors, sleep apnea, or for snoring, which is kind of a separate issue. Surgery used to be a really big thing, particularly before they got better machines and better masks. And essentially, they would go in and surgically remove all of this tissue. This had a fancy name, tonsillectomy and uvulopalatopharyngoplasty. And they would just open up all this space, kind of essentially they'd get rid of all that soft palate there, all this tissue on the side here, and create a bigger opening. That works fairly well for most sleep apnea until you get into severe sleep apnea where there's even tissue collapse further down here in the throat that this can't help. It is a major, major surgery, and given that in the most severe cases, that oftentimes it doesn't completely correct it, this is not done very often any longer. For more mild sleep apnea, and particularly for positional sleep apnea, if you're only having obstructive events when you're laying on your back, this is kind of the old school. You get your significant other to take a t-shirt and you sew a tennis ball into the back of it, and you stay off your back, and the sleep apnea is controlled. It sounds silly, but in certain people it actually works quite well. Also for snoring, sometimes it works quite well if your partner only snores in certain positions. So the mainstay of treatment these days is positive pressure ventilation. Comes in three main types: CPAP, which stands for continuous positive airway pressure; auto CPAP, which is essentially a newer technology that works well with the home sleep study, where instead of giving a set setting, we give a range; and then BiPAP, which is a biphasic positive pressure ventilation, positive airway pressure, sorry. In terms of the devices, they used to be much, much larger. Now, almost universally, the ones that are covered by your insurance are designed to be travel portable. They fit in a small bag, they are TSA compliant. This is kind of a more standard device. It's typically about the size of a notebook and probably about 2 to 3 inches thick. They actually make ones that are even smaller. This contains all of the tubing for this travel one, and that device, I mean, it fits in the palm of this guy's hand. These are probably a little out from most of your insurance covering them, but the point is they're relatively small and portable and easy to use. The main differences in the three different types: BiPAP tends to be the most expensive and is reserved if you really can't handle certain aspects of comfort, or you have very, very severe sleep apnea that have to be done with an in-lab sleep study. The way that CPAP works is that we note that the airway is collapsing. We give you some positive pressure, and that pressure kind of keeps those tissues separate and keeps it from collapsing while you're sleeping. So when you're awake, your muscle tone is keeping all of that airway open. The positive pressure replaces that muscle tone as you sleep, and it keeps the airway open. It gives a continuous pressure the whole time. You breathe in and out through that. I don't know if you've ever seen anyone who had bad emphysema, friend or loved one, and they sort of breathe kind of pursed-lipped breathing. That's the same kind of thing that patient kind of learned how to do to treat their illness. That keeps that back pressure and keeps airway there. So this works very successful. It's very good at keeping that airway collapse, preventing the interruptions from sleep, preventing the low oxygen levels. The advantage of the auto CPAP is that we have to pick a pressure based on watching how you do, and we alternate the pressures while you're sleeping to see which works best. Auto CPAP works well with a home sleep study because I just give a wide range, and this starts off at the lowest pressure, and it uses a feedback, and it notices if it's getting good airflow, it keeps it at that low pressure. If the airflow starts to be a problem, your breathing's interrupted, it increases that pressure up a little bit. It also can be a little bit more comfortable, particularly if in different positions you're going to need different pressures. As you are changing positions, rolling around in your sleep, the auto CPAP is going to automatically adjust the amount of pressure it's giving so that you're not getting woken up with a bunch of pressure on your face as you change positions. Okay? BiPAP is for a little bit more complicated, severe cases, and essentially it's typically a situation where the pressure to keep the airway open while you're breathing in is so high that it's hard to breathe out against it, and so this kind of adjusting drops the pressure down to help you breathe out a little bit easier. So when it comes to any of these, comfort is the most important thing. So 15, 20 years ago, there was pretty much one or two styles of masks. There were not a lot of incentive with insurance companies to make things that were very comfortable, because they typically just paid for one option, and so whatever could be made the cheapest was what got approved, and so everyone got a bunch of really expensive CPAP machines, and they never used them. So now we have a lot of different type of masks. This is sort of a traditional style mask. It covers the nose and the mouth. It goes above the chin. This is one that fits just around the nose itself. This is one that's called a nasal pillows. These actually fit in the nostrils. To me, this looks like the least comfortable possible thing, but this is by far and away what's preferred and most comfortable for most people. The tubing can be moved in different directions based on preferences. Some people don't like things by the side of their face. They have little random strange contraptions like this, where someone looks like an elephant. There's some chin straps. If you're a mouth breather and you're more comfortable with the nose, this kind of keeps your mouth closed. There's a lot of different options, and then beyond that, humidifying of the air is incredibly important when keeping these things comfortable so that you're able to use it. Because a CPAP machine, if you're not using it while you're trying to sleep, is not going to fix anything. Outpatient follow-up if you get diagnosed with sleep apnea. The main and most important thing is we have to be assessed for compliance. So this is particularly important because more and more primary care physicians are treating sleep apnea. They send you for referral for a sleep study. You have to, on the vast majority of insurances, including all of Medicare, be seen by a physician within 1 to 3 months to assess, and then they document your compliance. So when you come in, you get this gets printed out from your CPAP machine, and it shows the number of hours you use it each night, what pressures, if it's an auto CPAP, that they're having to give, and it gives what's considered the residual AHI, or your AHI number with treatment. And so that can make us know that this is working correctly, that you're not having those events. And then it's also important we make sure that it's comfortable. Is this mask not working? Is it that you need more humidity, less humidity? And is it controlling your symptoms, which is also incredibly important. If you're still waking up and you're exhausted all the time in the morning, maybe something else is going on. Maybe you have some other sleep issues that need to be tested further. If you have a lot of weight loss or weight gain, we may need to repeat a study. Typically for sleep apnea, the follow-up, it's that one visit there, and then if you're doing well, it's only once or twice a year. It's not a very intensive regimen, and that the biggest thing there is to make sure that if there are any issues, you need a new mask, you need new equipment, that insurance approves it, and it's been too long since you've seen your physician. So atrial fibrillation and obstructive sleep apnea. So in particular, we kind of talked about this before, but 50% of patients with atrial fibrillation are found to have obstructive sleep apnea. If you go the other way and you look at patients who have obstructive sleep apnea but no atrial fibrillation, you follow them. This was for about 4 years. 4% of patients with sleep apnea developed atrial fibrillation, and 2% of patients without sleep apnea developed atrial fibrillation. But when you get to severe obstructive sleep apnea, so that AHI number being over 30, and someone obesity, a body mass index greater than 35, that was 20%. So 1 out of 5 people with obstructive sleep apnea who are obese and have severe sleep apnea in 4 years have developed atrial fibrillation. So that's a pretty high number. And again, it kind of goes into, there's an interplay. Obstructive sleep apnea tends to cause AFib, and AFib can cause or at least worsen obstructive sleep apnea. If you have severe obstructive sleep apnea, the successful rate of medical therapies, whether that's rate control or rhythm control, is cut down in half. If you have less severe levels of obstructive sleep apnea, it's still a significant worsening of ability to control sleep apnea. It's just not that high. It's about a 10% reduction in success. And then the other thing is that control of sleep apnea increases the success of cardioversion and ablation procedures. If you have obstructive sleep apnea versus not having obstructive sleep apnea, and you get an ablation procedure or you get a cardioversion, there's about a half as successful rate of getting that to succeed and avoid recurrence of atrial fibrillation. And in particular, they looked at there's not a lot of randomized controlled trials in looking at this comparison, but there was one well-done study that looked at a bunch of patients who had atrial fibrillation and had sleep apnea, and it compared the groups who had sleep apnea but either didn't want treatment or were not tolerant of treatment versus those who were treated with CPAP, and compared that to a group without sleep apnea. They looked at the time that they were cardioverted, had an electrical cardioversion, and the rates of recurrence, you're about 1/3 with no sleep apnea. It was 70% with untreated sleep apnea had recurrence of atrial fibrillation within a year. Sorry, not a year. Where was that cut off? 5 years. And with treated sleep apnea, that was down to about 40%. Okay, so it gets you not completely down to someone with no sleep apnea, but incredibly close to that number. And so I think that treatment, if you have atrial fibrillation, you have symptoms of obstructive sleep apnea, you should certainly get screened, evaluated, and beyond just the symptom control, there's an advantage to getting your atrial fibrillation under control to use this, to put up with it. And the vast majority of patients that get diagnosed with this, even if it's primarily for a cardiac reason that they get referred, notice improved sleep quality, improved awakening during the day, beyond any of the advantages from a cardiovascular standpoint. So that's my presentation. With a lot of time for questions, if you'll have any. Yes, sir.
Suppose you have a lot of sinus trouble. Makes it tough to sleep.
So if you have a lot of sinus trouble and you get diagnosed with sleep apnea, so sinus trouble by itself can aggravate your sleep, but that doesn't necessarily mean that you have sleep apnea. But if you have sinus trouble and sleep apnea, it can be a difficulty with being able to tolerate the masks. You can do some nasal steroids at night. The humidification usually helps quite a bit. Sometimes we can add on some extra heating of the air to reduce some of the sinus inflammation there. And they actually make some masks that are designed, you kind of use a nose clip and they're designed to just go on the mouth. Or the standard mask that covers both the nose and mouth can work if you have bad sinus congestion and your nose gets stuffed up. And then the only other thing I'll say about that is the auto CPAP can help a little bit with that, because if your nasal congestion changes during the course of the night, if it notices more resistance, it's going to add a little bit more pressure, and sometimes it just needs a little bit more pressure to get past that, and it still works just fine. Does that answer your question? Yes, ma'am.
Is all snoring considered sleep apnea?
No, so I have physiologic snoring. My wife does not appreciate it, but it is not sleep apnea. Snoring, so snoring can happen essentially when this little piece here, your soft palate, or a little part of your tongue essentially starts vibrating and acts kind of like a whistle. The snoring can be a strong sign of that. The actual sleep apnea is the events where you end up where you stop breathing. This completely closes off, that snoring stops. So when you have someone, the common thing is they snore really bad, it's not just the noise, it's that it's inconsistent. That's all those pauses where actually somebody stops breathing. And so it's the stop breathing part that's typically sleep apnea.
Is there a connection between apnea and congestive heart failure?
So there is. With congestive heart failure, depending on some of the other risk factors, there's a much higher association with sleep apnea. There's sort of a little bit, for atrial fibrillation, I think it's a little bit clearer that it provides some benefits. There's not as good of information in terms of heart failure that treating sleep apnea will help the heart failure. We used to think that was a given, but it's not as clear. Certainly if you're having symptoms, it's appropriate to treat it, and it has to be, we have to avoid some certain stranger technologies that people have invented that actually can make heart failure worse, but none of the things that I talked about. But it's not as clear-cut of an association of if you treat the sleep apnea, heart failure gets better. We may find that out in the future, but it's not there yet. Yes?
How common is central sleep apnea?
So I didn't talk too much about central sleep apneas. Those, pretty much need to be diagnosed with an in-lab sleep study. There is 2 different factors for that. There's some that's pure central sleep apnea. So that has nothing to do with these airways. That has to do with a brain signal to the body for attempting to initiate a breath, and that goes away. That can be triggered because of heart failure. It can be triggered because of severe lung disease and certain neurologic diseases. And then there's also, you can get just from severe sleep apnea, you can get, from obstructive sleep apnea, you can get central apneas. So when you have a combination of obstructive and central apneas, if you had a sleep study, the central apneas were probably actually related to your obstructive apnea. If you only have central apneas, that is actually the brain not sending a signal to the body to breathe for periods of time, your oxygen goes down. That gets into some complicated physiology about you're getting overly used to low oxygen levels and to actually an overstimulation of the respiratory drive, which then leads to desensitization. It would probably take me about an hour to fully go through it to some med students. But they're very, very different things, and there's not a clear association of the treatment of central sleep apneas with improving heart outcomes. In general, central sleep apneas without obstructive apnea is in general a sign of poorer health.
Is there any indication, are you aware of any research that says it's central is due to heredity in any way?
Due to heredity? I am not particularly aware of that, other than in some infant related diseases that I don't treat pediatrics, but I know there are certain issues with hypoventilation of sleep related to some things that happen in infancy that are hereditary. But I'm not aware of it in adulthood. There may be, but I'm not aware of it.
Can CPAP actually clear up AFib eventually?
Can it clear up AFib? You would never want to be your only treatment for atrial fibrillation is CPAP. But particularly if you had bad obstructive sleep apnea that led to atrial fibrillation, treating that is more likely to allow that to get under control. So again, when they looked at all these numbers, unfortunately they don't go back through and look at people who were treated for the most part. They were using screening, and most of the stuff is from around the 2000s, and most of the people who got diagnosed with sleep apnea weren't comfortable on their masks and just didn't use them. They had these really expensive machines they never used, and so we didn't get people a lot of other treatment. So we know that the medicines are less effective. We know that the procedures are less effective for atrial fibrillation. I think it's a little bit of everything. If your atrial fibrillation is entirely caused by you drinking 20 coffees in a day, you get rid of the coffee, that may be all it takes to get your atrial fibrillation gone. I don't think there are going to be as clear a cases of someone that's AFib is only caused by sleep apnea. If that was the case, it would be a similar thing, but really the goal here is to supplement the atrial fibrillation treatments, not to cure.
We've rarely seen it. That can happen. So a common thing we hear in our office is patients complain that no matter what they do, they just cannot wear the mask. So when you hear the "I can't wear the mask" symptom, what is your approach to?
So one of the things that we try and get for why you can't wear the mask. So some people feel like the air is too dry. Some people feel like there's too much pressure, particularly when they're first trying to go to sleep. The other thing is comfort. So like I said, this looks incredibly uncomfortable to me, and I think a lot of people avoid it just because of the concept. But if I surveyed all of my patients, I'd say over half of them end up settling on the nasal pillows that settles in there. So one of the key things is trying different masks. The problem that we run into is that depending on your insurance, you're going to have a different supplier. There are some suppliers who are amazingly good. There's one supplier with a storefront right on Veterans that you go in, you can try on any mask, they'll sit there with you, play around with all these things. I have other suppliers that try and ship out a machine with no education, with one mask, with no options, and I'm having to hassle them to send out a different mask. That is a frustration of mine with insurance companies, but we don't have full control over that. But if you are describing symptoms and I pester insurance companies enough, usually I can get a mask. It's just not as ideal of a situation you're going on and trying on different things and physically seeing them. Humidification is important, making sure that it's the right amount of humidity is important. And then there's a couple of things that we can actually do to adjust the pressures and adjust that comfort. If people are having a lot of sensation of too much pressure when first trying to go to sleep, we can do something called a ramp that slowly increases the pressures. I'm trying to think of some other, some people it's nasal congestion and we have to worry about adjustments on certain of their nasal routine and focusing it, because most people tend to do that in the morning, doing it at night so you can wear your mask. That's most of it. It's kind of talking it through with the patients primarily to figure out why.
So what percentage of your patients, where no matter what you do,
Just
just
won't.
can't make it work?
It's hard to know. I'd say it's probably 5 or 10% that just absolutely can't do it. I think there are more people who get referred primarily due to the spouse not liking the snoring. They get diagnosed with sleep apnea. They feel like it doesn't bother them and they just don't want to bother with it. That's usually my primary issue when people just stop wanting to try. If you're having a lot of symptoms, if you're not sleeping well at night, and you're really tired during the day, if you can get that under control, you feel like a new person, and that usually is enough to get people to put up with the inconveniences.
We find that we refer a lot of patients for this kind of strategy because our literature is full of studies linking sleep apnea to AFib, but we find, I don't want to indict our primary care doctors, but a lot of time treatment's prescribed, but there's not enough follow-up or not enough sit down with the patient and really try to work through the issues, and then patients get frustrated with it and they just say to hell with it.
Yeah,
It's such a shame because I think that happens too often.
Yeah, and I think it also ties into the just like the masks have gotten a lot better for comfort. It used to be that to see how well the CPAP machine was working, the patient had to take their CPAP machine in. You had to have someone who knew how to put in the right code to get the download information, to get actually how it was working. Now they can remotely do these downloads or just pull a little card out and take it to their provider, their medical equipment provider, and we get these downloads a lot easier. So it's a lot easier to get that feedback. And then there's a lack of sleep education in residency programs beyond getting into a fellowship for sleep or pulmonary. So.
Once you have a diagnosis of sleep apnea, do you always have it?
So we can, in certain circumstances, sort of retest people and see if it goes away. The primary thing there is significant weight loss. I've seen people who completely no longer have sleep apnea with weight loss. But we talk about weight a lot, but that's not the only factor involved. Some people just have naturally narrower necks, more tissue back there, and you can have someone who's as thin as Dr. Zhao who has horrible sleep apnea. And so it doesn't all connect that way. But for the most part, unless there's a big change in one of those things that led to or caused sleep apnea, it persists.
You mentioned in all the sessions about caffeine, alcohol, and some nasal sprays. Is there a particular nasal spray
For which?
a nasal spray for sinus?
Oh, to try and help with sinuses if you're having difficulty tolerating it?
Yeah, and it
Oh.
might contribute to atrial fib.
We find a lot of pseudoephedrine containing
Oh.
congestant, so
Yeah, no, I would not recommend any of those kind of nasal sprays. Beyond their effects on atrial fibrillation, they tend to actually cause a rebound swelling of the nasal passages after they start to wear off.
If it contains what?
Like pseudoephedrine, Afrin, those kind of medications I would avoid. The ones that you want to use are nasal steroid sprays, Nasacort, Flonase, Nasonex. There's no set brand. You find the one that has the smell that you tolerate and
Neosynephrine is not good.
Neosynephrine, I believe that's Afrin, right? Is that, yeah. So that one tends to, what happens is it's getting way outside of this, but what happens is that you spray it, your nasal passages shrink down, but then within about 15 to 30 minutes they're back to normal, and then they get a rebound effect where they actually swell up more. So so I would avoid that with whether or not you have atrial fibrillation.
What about bariatric surgery? A lot of you patients have bariatric surgery and notice that they don't need their mask anymore?
When they get bariatric surgery and they end up having significant weight loss, we typically will retest and see. A lot of them will at the very least end up with a lot lower pressures or pressure settings. There are a few that absolutely, it completely resolves and it goes away. I've even had a couple who just purely with diet lost weight, and it's one of those people, they no longer had hypertension, no longer had diabetes, and they no longer had sleep apnea, which is...
This is a poll. How many patients who want to answer the poll have been diagnosed with obstructive sleep apnea? How many can't wear masks?
I have a question, actually.
Yeah.
If you use the nasal mask only,
Mhm.
and you may or may not be mouth breathing, does mouth breathing defeat the benefit of the pressures?
So it a little bit depends on what device you have. If you have an auto CPAP, it'll often be able to increase that amount of pressure to be enough. The big thing that if you're a mouth breather and using a nasal mask is that air starts to blow out of your mouth, and it tends to make a really loud noise and wake you up in the middle of the night, or wake your spouse up in the middle of the night. And so they have these little chin straps. You can get it prescribed. You can also, they can get ones that you can just get online that are made out of some more comfortable material. The ones that are covered by insurance usually aren't overly comfortable, and it just keeps the chin up while you're sleeping. But yeah, it can be a problem. Usually the chin strap is the best thing. You just got to find one that's comfortable. But usually what causes that problem is that it wakes you up when the air starts blowing out of your mouth. Do you have a nasal mask?
I do.
Is that what tends to happen, or you just sleep through it just fine?
I tend to sleep through it, but my wife thinks it's not working, so.
So again, if whoever is prescribing it can get the download, and it gives this, through some feedback mechanisms, it can get whether or not there's good control. It's called a residual HI, and that will still work even if you're a mouth breather, and so it'll tell us if it's working from that perspective. If she feels like it's not working, it may be that noise is to her just as bad as your snoring was. I don't know, but that may be the issue. But that's usually the problem. It makes a lot of noise.
So we've seen a lot of companies even try to come market to us about, I think they're going to the primary care doctors too, about the simplified home sleep study. We had a slide with it, but I think we've seen some patients where there's been this kind of incomplete workup, and you want to comment on that a little
So,
bit?
the home sleep study is only for obstructive sleep apnea. So if you're having other signs or symptoms that your doctor's concerned about some other kind of sleep disorder breathing, it's not going to work. If you don't want to have sleep apnea, then you can go home and sit there with that thing and turn it on and then just refuse to go to sleep, and wow, congratulations, the test shows you don't have sleep apnea. So it's not perfect. It's not going to completely rule out sleep apnea, and it takes some effort on the patient's part to make sure that you're cooperating with the study and not trying to manipulate the study. The other thing is that if the concern is high enough, or someone has a very high suspicion for sleep apnea, it may be that you're waking up so often, you have such bad sleep apnea that you spend the vast majority of the night awake, of no fault of your own, trying to sleep. And again, this machine is going to look at what your average is for the course of, let's say you're laying in the bed for 8 hours, but you only got 2 hours of sleep. Well, it's only going to it should have divided all of those events by 2 hours, but it's dividing it by 8 hours. So it's cut your number in 4. And so when we're very suspicious about sleep apnea, we can start with a home sleep study, but if it comes back negative, then we need to do an in-lab sleep study.
How well do patients who just simply have O2 sat monitoring in the hospital, you know, we have desaturations, nocturnal desaturations, how well does that correlate with you finding in the sleep study? It's called a cheap man's sleep study, but
It's the poor man's sleep study. The problem is that the poor man's sleep study leads to the poor man's treatment, which is home oxygen, which I didn't get into. But if you have sleep apnea and you're only put on home oxygen, it can actually worsen sleep apnea. It may help with atrial fibrillation issues, but it's going to worsen sleep apnea. If I get a call that someone is in the hospital having frequent drops in their oxygen saturations at night, what I typically do is just set them up for a home sleep study, and then we get the information there. I don't try and do them in the hospital because in general, same problem. Nurses are waking somebody up over and over again. They have a loud neighbor, and all of a sudden they get a diagnosis of a normal sleep study when it didn't mean anything.
Well, that was superbly done and just at the right level. And you know, again, we're frustrated by a lot of the, you know, I think some of the problem too is patients when they wear the mask, it's almost a phobia. It's like it's not necessarily a physical thing, it's a mental thing about the necessity of, or this being,
I think
people described in a variety of different terms.
claustrophobia is the big thing with this mask because you can't really open your mouth. It's a lot of pressure. I think that's the big problem with this mask, which is a traditional mask. It's the mask that if you got admitted to the hospital and you were sicker and they had to put you on BiPAP, it's the one we have in the hospital. So everybody associates it the same. They didn't like the feel of it. So I think that's a big push there. Humidity, the dry air, the amount of pressure is a big thing. So some people when they're first going to sleep can't handle that amount of pressure, but then once they fall asleep, they stay asleep just fine with it controlling things, and so we can slowly ramp the pressure up. There's options to help with the sensations of it being uncomfortable, but I think I agree with you. I think it's a fear initially of starting on it, and if you can get through that, you can get your good night's sleep. Then once you see the results, then you tend to be a lot easier to do it.
Well, I mean, this is a critical area for the folks in this room who have AFib because, you know, Dr. Zhao and I always stress that sleep apnea, undiagnosed sleep apnea is one of the main impediments to therapy. Unfortunately, we don't have as good a data in our literature as we'd like. It's our, you know, we base that on our own experience that we always counsel patients that unless the sleep apnea is treated, we're not going to have a great success rate with medical therapy. And even in the post-ablation patients, we find that the ones who either refuse to have the workup or don't want to get treated once the workup establishes a diagnosis, they tend to do worse. That's not true of everybody, but as a general trend, it's true. So we view this as a very critical component of our treatment, and I think even our general cardiology colleagues are coming on board with this too.
Yep.
So we look forward to working with you a lot more in this area. That was well done, superb. All right, guys. So Sharon's going to work with you. We're going to meet again.